So good evening, Doctor. I Shuman on behalf of Shield Healthcare, welcoming you all in today's webinar. And the topic of the today's webinar is respiratory tract infections and immunomodulators. And our guest speaker is Dr. Abhijit Chandra, sir. It's my honor to introduce sir. Sir did his MBBS in the year 1990 from Calcutta University, from Nilathan Sarkar Medical College and Hospital, DMB in 1994, DTMNH in 1997 from Calcutta University School of Tropical Medicine. Sir is the Senior Registrar Consultant Physician at Gamma Centauri Healthcare Private Limited. Sir completed his PHFI course in ACMDC and CCMDT in 2015. Sir is the Consultant Physician in General Medicine in PLS Hospital City Diagnostic Center. Sir is the Medical Officer, ICCU Anandalo Hospital, Kolkata. And apart from that, Sir has many publications in journal of well reputed. In this short introduction, I request sir to take over the session. And meanwhile, I request all the participants for their active participation, and please post your queries on the Shield Connect page. So once the webinar will be over, we shall have a short discussion on this topic with sir. So thank you, sir, and over to you, sir.
Right.
Hi, sir.
So we are starting today's topic, dear respected colleagues. Today our topic is respiratory infection immunomodulators. This is a hot topic. Respiratory infection refers to
Sir, can you full screen it, sir, with enable editing?
respiratory infection refers to any number of infectious diseases involving the respiratory tract. It is classified in two types of infection: upper respiratory infection and lower respiratory infection. Because of immunity and increasing reliance of high risk mixed social environments, recurrent respiratory infection causes a major burden to healthcare. Despite the viral cause, respiratory infections are a significant source of antibiotic misuse and are associated with both direct cost and increased risk of wheezing and asthma. Prevention is key in order to reduce this burden of healthcare and the associated increased risk of asthma. Upper respiratory infection, URI or UTI or illness caused by an acute infection which involves the upper respiratory tract, nose, sinuses, pharynx or larynx. These commonly include tonsillitis, pharyngitis, laryngitis, sinusitis, otitis media, and common cold. Infection of air passage within the lungs are called upper respiratory infection. Trachea, about lower respiratory infection, it is the infection of air passage within the lungs. Trachea, windpipe, and the large and small bronchi airways within the lung become inflamed because of the respiratory infection. It is divided into two types: bronchitis and pneumonia. Bronchitis is upper bronchus up to the level of bronchus. They involve up to the level of bronchus, and pneumonitis, bronchitis, chest involves more central areas, and pneumonia involves at the level of alveoli beyond bronchus or lower divisions, and there is consolidation on chest X-ray. Cause of lower respiratory infection are virus like rhinovirus, coronavirus, adenovirus, and bacteria like group A, streptococcus, influenza virus, and is aggravated smoking and environmental pollution. Risk factors are physical and close contact with someone with a upper respiratory infection, poor hand washing after contact with an individual with upper respiratory infection, close contact in a group setting like theater, school, or daycare center, contact with group of individuals in a closed setting such as traveling, tour, and cruises. Role of immune system in respiratory infection. There are three agenda: defense against microbes, defense against growth of tumor cells, kills growth of tumors, and homeostasis, destruction of abnormal or dead cells like dead red RBC or WC, anti-antibody complex. Immune system have three components. Important components are granulocyte, complement synthesis, antibody formation, cellular immunity, and mucocutaneous barrier. Immune response is initially after primary anti-exposition lag phase. Initially, the immune system does not respond. There is some lag phase. After that primary immune response, low degree, low titer of IgM, then there is some negative phase, the sudden drop in IgM level. After they, when the second challenge, the secondary antigen exposure, there is secondary immune response in the form of Ig level. The Ig level is of high titer. The long encounters of myriad of potentially foreign particles. Larger particles are deposited in the nasopharynx and tonsillar regions and cleared by inertial forces like coughing and sneezing. Further down the respiratory tract, foreign particles are captured on the mucociliary surface and propelled back on an escalator by rhythmic movement of microscopic hair-like cilia to the upper airways from where they are expelled. Various antimicrobial compounds exist within the mucous layer, including collectins such as surfactant proteins or lipopolysaccharide binding protein, a protein that binds bacterial lipopolysaccharide, and they bind to cell walls, allowing their uptake by immune cells. Mechanism of immunomodulation. Drugs may module immune mechanisms by either suppressing or by stimulating one or more of the following steps: antigen recognition and phagocytosis, lymphocyte proliferation and differentiation, synthesis of antibodies, antigen-antibody interaction, release of mediators due to immune response, and modification of target tissue response. The importance of immune system in protecting the body against harmful molecules is well recognized. However, in some instances, this protection can result in serious problems. For example, the introduction of allograft can elicit a damaging immune response, causing rejection of the transplant tissue. Benefits of immunomodulators stem from their ability to stimulate natural and adaptive defense mechanisms such as cytokines, which enables the body to help itself. Natural immunomodulators act to strengthen weak immune system and to moderate immune systems that are overactive. Plant sterols and sterolins are natural immunomodulators found in some raw fruits and vegetables and in algae and spirulina. There is a schematic view of lung immune cells and response. The lung encounters pulmonary microbiota remains in the pulmonary hemostasis. There is some normal pulmonary microbiome that maintains the pulmonary immune homeostasis. And there are also immune components like AEC or BC and antigen presenting cells, non-ciliated specialized cells, epithelial cells, and there is a recruiting lymphocytes from circulation, partial lymphoid tissue, and there's alveolar interstitial macrophage T cells and B cells, and different interstitial cells and pulmonary neutrophil infiltrated during infection. There is structure of the respiratory mucosal immune system. There's a goblet cell, B cell, T cell, dendritic cell, cytokines, and there is thick mucus layer. It is in the trachea, and in the alveolus there is some bronchus associated lymphoid tissue that involves B cell, T cell, and dendritic cell. And in the alveolar level, there are type 1 epithelial cells, parenchymal B cells, type 2 epithelial cells, parenchymal dendritic cell, blood vessels and medulla, and parenchymal T cell. And there are some regional lymph nodes that home lymphocytes, and that can cause lung homing and systemic. They also go for systemic distribution. Microfold cells. specialize in antigen uptake and their presence in respiratory mucosal immune system. The cilia of the microfold cells are shorter than those of conventional epithelial cells. On its basal side, the M cell develops a pocket-like structure that can hold the immunocompetent cells. M cells, like macrophages, function in active antigen uptake. Because lysosome development in M cells is poor, in most cases, the incorporated antigen are just passed to the M cells unmodified and then taken up by the dendritic cells. In addition to M cells, dendritic cells are located in pulmonary alveoli and express CD cluster of differentiation number 103, or in intestine and express CXC41, CXCR1, and can directly take up the luminal antigens by extending the dendrites. M cells can be found in three different locations in the respiratory tract, namely NALTFE and the respiratory epithelium and IVALTFE. Nasal cavity and interstitial, bronchus associated lymphoid tissue, or nasal cavity associated lymphoid tissue. Immune response to viral infection or innate immune response, like general response to any infection. Innate immune responses secrete interferon and other chemicals like cytokines. Interferons interfere with virus replication. The infection can be stopped at this stage. When the infection stopped at this stage, stage 2 is triggered. That is adaptive immune response. Specific response to the infection starts after 6 to 8 days, involves two types of white blood cells, T cells and B cells. Interferon cytokines cause fever, muscle ache, early symptoms in the infection in step 1, and weak net response. Elderly people or those with underlying health problems may result in delayed stimulation of adaptive response. Immunomodulators are certain natural and synthetic compounds that can modulate immune response in positive or negative manner. Immunomodulator of three types: immunostimulant, immunosuppressant, and immunoadjuvant. Immunomodulators are immunostimulant, specific immunostimulant, and non-specific immunostimulant. And they activate the immune system, enhance the defense mechanism used in treatment of cancer and infection. Immunosuppressant are specific and non-specific, and they suppress the immune system. And anti-infection medications in organ transplant and treatment in autoimmune disorders like steroid and azathioprine, they are immunosuppressant. And we have various targets and basic principles of functioning of immunomodulators. B cells, there is immunomodulators. They act on via transcription factor. They also act via free radicals and lipid peroxidation, and they also involve apoptosis path. And they also involve the complement pathway. They affect the protein synthesis and antigen presentation. And they act via on T cells via interferon, cytokine, and interleukins, and on via B cells producing serum immunoglobulin. Immunosuppressants are glucocorticoids, calcium inducers like cyclosporin and tacrolimus, anti-proliferative or anti-metabolic agents like sirolimus, everolimus, azathioprine, mycophenolate, mofetil, and methotrexate, cyclophosphamide, thalidomide, and chlorambucil. Antibody like anti-thymocyte globulin, anti-CD3 monoclonal antibody, neuromonab, anti-interleukin 2 receptor antibody like daclizumab and basiliximab, anti-TNF T1 necrosis factor alpha like infliximab or etanercept. Immunosuppressants are the drugs which inhibit cellular and humoral or both types of immune response and have their major use in organ transplantation and autoimmune disease. Problems can arise from lifelong use like resistant infection, cancer, nephrotoxic, and they also induce diabetes. Immunostimulants include levonazole, thalidomide, Bacillus camellitic, BCG, and recombinant cytokine like interferon and interleukin 2. Immunomodulation recurrent respiratory infections. Respiratory tract infections are extremely common in pediatric population. Infection frequency more than 8 or more episodes per year in infants, 6 and more episodes per year in children above 3 years old is considered to represent recurrence. Child itself with its temporary immune system immaturity may be said to be the primary cause of respiratory infection in pediatric population. Viruses are responsible for most respiratory tract infection, more than 80% cases. Common causal agents include human rhinovirus, human respiratory syncytial virus, adenovirus, and influenza virus. Bacterial species also represent ecological agents both alone and as bacterial superinfections, commonly following acute viral infections. Viral infections cause and contribute to serious respiratory conditions, which may result in hospitalization. Risk factor for recurrent respiratory infection: daycare attendee, early socialization, large family size and overcrowding, positive family history of atopic disease, school-aged siblings, prematurity, low body weight infants, reduction of breastfeeding, climate and environmental factors, indoor and outdoor pollution, exposure, home dampness, pets at home, especially cats and dogs, parental smoking and smoking in pregnancy, anatomic or functional alterations of the upper and lower airways, allergy and atopy, gastroesophageal reflux, male gender, poor socioeconomic conditions with malnutrition, intense training and physical stress, and missed vaccination. Immunomodulators in respiratory infection. OM85 is the product of alkaline lysis of 21 strains of common bacterial respiratory tract pathogen. OM85 includes dendritic cell activation and release chemokines that act on monocytes and natural killer cells, and it has demonstrated efficacy in number of forms of pancreatic respiratory tract infection. OM85. Second one is pitotimod. Pitotimod is synthetic thymic dipeptide. It causes maturation of mucosal dendritic cell and promotes proliferation of T cells, monocyte, and cytokine, and reduce fever through fever, cough, and pulmonary ralls, and duration of symptoms. And third one is ribomunil. It is a mixture of bacterial proteoglycans and ribosomes. Ribomunil induced dendritic cells stimulate T cells, causing antiviral interferon gamma release. And ribomunil reduce the incidence, prevalence, and duration of infection. Immunization includes vaccination, immunoglobulin, and research D immunoglobulin. Now discuss about curcumin. Curcumin is derived from turmeric or curcuma longa, and it has this chemical structure. It has multifaceted activity. Like it is antioxidant, it is anti-mutagen, anti-metastatic, anti-angiogenic, immunomodulatory, neuroprotective, anti-inflammatory, antiviral, antifungal, and antibacterial. Curcumin uses schematic diagram immunomodulatory effect of curcumin. It is a schematic representation of main molecular pathway lead to inflammation and immunomodulatory activities modulated by curcumin echinacea. The solid red lines indicate the activation of pathway, whereas the truncated red lines indicate inhibition of pathway. It inactivates the MAPK and NFK. MAPK is mutagen associated protein kinase units, and NFK is nuclear factor kappa beta, and tool-like receptor 4, they are get inhibited, and it actually associates suppressor of cytokine signaling proteins. Role of immunomodulators in COVID-19. In COVID-19 immunity, in healthy immune response, infected cells A rapidly cleared virus inactivated by neutralizing antibodies and minimal inflammation of lung damage. If the in COVID-19 in normal respiratory infections, the when it encounters a healthy immune system, the infected cells are rapidly cleared, virus inactivated by neutralizing antibodies, and minimal inflammation and lung damage is there. But in COVID-19 patient, there is vascular infiltration with T cells and macrophage, and there is systemic cytokine storm and pulmonary edema, pneumonia, and widespread inflammation. Effective immune response against viral infections depends on activation of cytotoxic T cells. 92.1% COVID-19 cases display low circulating lymphocyte count. At granular level, in COVID-19 infection, total T cell count CD4 and CD8 T cells are significantly reduced, thus induces viral survival. Thus, it induces virus survival. Prolong the coronavirus-related infection more severe, symptoms are more severe, and so also mortality. And in case of adaptive immunity, it induces neutrophil, monocyte, macrophage, and dendritic cells and results in production of various pro-inflammatory cytokine like TNF alpha, interleukin 6, interleukin 10. It is called cytokine storm and leads to lung edema and tissue damage. High levels of pro-inflammatory cytokines results in mobilization of various immune cells like neutrophil, macrophage, and T cells from blood circulation into infected tissue. And this leads to diffuse alveolar damage, capillary damage, vascular barrier damage, multi-organ failure, and ultimately death. Viral infection via ACE2 angiotensin converting enzyme 2 receptors and viral influx, and they affect the coronavirus infect gets entry into cell through ACE2 receptors, and after that gets replicated and matured within cells. Activation of T cells, monocyte, and macrophage will release of interleukin 6, interleukin 1, etc. And the therapy is targeted to specific components of inflammatory cascade, includes macrophage activation and cytokine storm modulated by inhibition of interleukin 6. Interleukin 6 is blocked by tocilizumab, sarilumab, cetuximab, and steroids like dexamethasone and prednisolone. Interleukin 1 receptor blocker canakinumab, rilonacept, and Janus kinase inhibitor like baricitinib and tofacitinib. And TNF alpha, adalimumab, etanercept, infliximab, and inflammasome colchicine. And activation and release of inflammatory mediators causing pulmonary edema, pneumonia, and cytokine storm. They are blocked by antimicrobial treatment like azithromycin and penicillin, and alveolar macrophage clear neutralization by neutralizing antibodies inactivate virus CD4 CD8 cells mediate immune response so that virus can be cleared. Innate and adaptive host immunity resolves infection effectively. Treatment to reduce viral load and replication like lopinavir, ritonavir, remdesivir, baricitinib, chloroquine, hydroxyquine, they are question to solve. Pitotimod, 3L pyrobutamyl L thiazolidine 4 carboxylic acid. It is a synthetic dipeptide molecule with immunomodulatory properties. It is highly purified molecule with high reproducibility, acts on immunostimulant, immunoactivator, and immunomodulator, and oral synthetic biological response modifier. Pituitary and innate immunity. It upregulates immunity. It induces dendritic cells maturation. It downregulates monocyte chemoattractive protein 1, thus prevent cytokine storm activation. It functional is to recruit cells like monocyte, macrophage, dendritic cells at the site of inflammation, produce either a tissue injury or infection. It also upregulates tolerate receptor 2, thus prevents lung tissue damage. And in case of adaptive immunity, it upregulates adaptive immunity. It helps T cell proliferation, thus reduce duration of symptoms. This is the scheme. Pituitary balances T helper 1 and T helper 2 cytokine balance. And in respiratory infection, if we use pituitary, it enhances secretion of interferon gamma, Th1 cells and interleukin 12, and they downregulate secretion of interleukin 4. The cell immunity delays hypersensitivity depending on interferon gamma. The strategies can boost respiratory immunity. Patient gets enough sleep, eat more. You have to boost the respiratory immunity. You have to get enough sleep, eat more whole plant foods, eat more healthy fats, eat more fermented foods, or take a probiotic supplement. Go for moderate exercise, stay hydrated, and manage your stress level. Probiotic for airway, potential to improve epithelial and immune homeostasis. Probiotics, there are some protein called MAMs, and they are important for epithelial barrier. Clinical applications include allergic rhinitis, chronic rhinosinusitis, and asthma. Microbiome diversity and inflammation. If the mucus layer is decreased, there is more inflammation. If there is a microbiome, normal microbiome is dense with recurrent and antibiotic antibiotic diversity will be hampered. So also the epithelial permeability, and if the epithelial permeability is decreased, mucus level is destroyed, there will be more inflammation because of the more entry of viruses. The gut-lung immune axis illustrates the points of immunomodulator activity in respiratory profile axis. These are the sites where OM85, pituitary mod, ribomodil, PMLB, and LW5020. They are experimental molecules. They induce homing, selective circulation. And role of vitamin D in respiratory disease. There is strong correlation between chronic inflammatory disease and low vitamin D levels. 80% of vitamin D comes from endogenous production from 7-dihydrocholesterol in the skin after exposure to ultraviolet radiation from the sun. Cholecalciferol vitamin D3 is the form that is stored in tissue such as liver and adipocytes. The prohormone requires two hydroxylation, the first in liver, then second in the kidney to become biologically active form. 125 hydroxy cholecal D3 or calcitriol. Vitamin D is the activated form. 125 hydroxy calcitriol is an immune modulator hormone with beneficial effects on T-cell mediated autoimmune disease. Key points. Immunity is the balanced state of multicellular organism having adequate biological defense to fight infectious disease and other unwanted immunization, while having adequate tolerance to avoid allergy or autoimmune disease. And the divergence of individual innate and adaptive immunizations may contribute to explain the clinical manifestation spectrum of severe SARS-CoV-2 infection. Immunological memory to SARS-CoV-2 has been demonstrated in patient convalescent from severe and mild COVID-19. It is necessary to establish whether individuals previously infected with SARS-CoV-2 should be vaccinated or need tailored immunization protocol. Pitotimus as an immunomodulator is something to consider for. Because of immunological immunity and the increasing reliance on high-risk mixed social environments, recurrent respiratory illness causes a major burden to healthcare. Despite their overwhelmingly viral cause, respiratory infections are significant source of antibiotic misuse and are associated with both direct cost and increased risk of wheezing and asthma. Prevention is the key in order to reduce this burden of care and associate the increased risk of respiratory infection. Thank you.
Thank you very much, sir, for this nice presentation. Meanwhile, I receive few questions. So if you allow me, then sir, we can go first. So the first question is, in case of upper respiratory tract infection, if it is related to some viral infection, so does antibiotic helps in a way? So what is the relation of the antibiotic in case of viral infection?
Now, in the beginning, just on clinical basis, you cannot know whether it is viral or bacterial. There is no viral lab and the diagnosis is not clear cut. So you can use prophylactic antibiotic. And for recurrent respiratory infection, for the initial viral infection, the body immunity gets reduced and there is every chance of getting bacterial super infection.
Okay, sir.
So prophylactic antibiotic may help to some extent.
Okay, sir. And sir, how long can it be prescribed? Means in case of URTL.
3 or 5 days, depending on the severity of the infection and age of the patient, age of the subject.
And sir, another question is, as in this COVID pandemic situation, is it right to suggest some immunomodulators in terms of some nutraceuticals or so to improve the immunity?
It is a new disease, we have to learn new things, and uh, if there is some survival benefit or the after vaccination, if there is some molecules give survival benefit and scientifically and on the basis of current knowledge, it induces immunity, then why not use it? Better to use it and publish some papers, have the clinical experience. At least it is not going to kill anyone.
Okay, sir. Thank you, sir. And sir, one question is that is in recent research articles, it has seen that vitamin D has a great role in case of RTS. So, what is your opinion on that?
Vitamin D is a very important tool. We have to use 16 daily initially for someone is using daily for initial 3 or 5 days. After that, we are using it weekly. So use the if there is any underlying vitamin D low vitamin D level, we have to boost it up as early as possible, either by injection or oral heavy dose high dose vitamin D. It is the recommendation.
Okay, sir. And sir, another question is, as sir, we came to know that COVID-19 is related to the S2 inhibitor, S2 receptor, and which is less expressed in the pediatric patient. But in the third wave, maybe it is expecting that childs are mostly prone to affect on the disease. So, what is
Then,
the reason on that?
because the virus are getting virulent, they are having uh, separate mechanisms and unknown routes to affect individuals. And initially, in the third day, it may happen that RT-PCR may be negative because the infection is virus is more infection. The delta plus T is more infectious, about 1,860 times more uh, infectious than the previous one, and possibly the incubation period is short, 2 or 3 days, and in that in the period you may not get the RT-PCR positive. That will be there will be problem in the diagnosis, and the first wave affected the older people, elderly people more, and the second wave affected the younger ones. So there is concern that children may affected more in this third wave. There is no scientific basis, but you have to wait and watch, and you will cause us. There is some concern.
So, thank you, sir. And I want to share one thing that in terms of respiratory immunity, also, rudimin is there, which is a combination of bioactive vitamins and antioxidants. So, thank you very much, sir, for your valuable time. And just if you allow me, then we can start a video of less than 2 minutes.
Please start to.
Yeah, Uma Shankarji, you can start.
Doctor has to stop sharing.
Yes. Sir, you can stop share.
Stop. stop share করে।
Shankar ji, you can share.
Yeah, yes, sir.
Dr. Shield Healthcare, Transforming Health with Innovation and Technology, is the winner of the prestigious Indian Health and Wellness Award. Likes to thank you for helping us achieve through your valuable partnership. Health issues like recurrent respiratory infections can cause complex physiological and biochemical changes leading to ambulatory condition. Therefore, we need a specific immune booster to strengthen the respiratory immunity. So, introducing Rudimin Mu tablets and Rudimin Mu syrup to strengthen the respiratory immunity. Rudimin Mu tablets and syrup are a specific combination of 4 bioactive ingredients along with immunovitamins and minerals. The bioactive ingredients are tinocoridin, curcuminoids, Asimenin, Osimum sanctum. Rudimin Mu is also enriched with immunovitamins like vitamin A, vitamin C, vitamin D3 and minerals like zinc and selenium. As per ESPN guidelines May 20, daily allowance of vitamins, minerals and trace elements maximizes nutritional defense for patients susceptible to frequent respiratory infections. Therefore, please prescribe Rudimin Mu tablets and syrup in recurrent respiratory infections. Only Rudimin Mu strengthens the respiratory immunity. Dose of Rudimin Mu tablet is 1 tablet BID. Dose of Rudimin Mu syrup is 5 ml BID. Doctor, Rudimin Mu shields immunity. Thank you.
So thank you very much, sir. Thank you
Hello.
very much, sir, for your valuable time once again. In future also, I look forward for some valuable session from you. So with your permission, sir, we can conclude the session.
Thank you.